بسم الله الرحمن الرحيم. محاضرة اليوم في مادة oral surgery تتعلق بالألر system that have the management of renal diseases. Before starting the renal disease, we have short anatomy and physiology about the urinary system. The urinary system have its part from first right and left kidney and right and left ureter and the gallbladder and the urethra. This is all part of the urinary system, and there are two artery, renal artery and renal vein that have its blood supply of the left and right kidney. This figure shows the component of the urinary system. It is two parts, the kidney and urinary tract. The kidney have right and left kidney and its arterial blood supply and through renal artery and venous drainage through renal vein. And we have urinary tract start with the ureter and the bladder and in it through urethra, so the accumulation of urine through the kidney to the ureter to the bladder and go outside our body through the urethra. The anatomy of the kidney have two parts that have upper parts, outer part is cortical part and the inner part is the spongy part. The left kidney on a cross section that have glomeruli and canal that combination as forming pelvis of the kidney and the pelvis that go outside of the kidney to form the ureter. We have two kidneys at left and right. The structure of the kidney that have a capsule that's surrounding the kidney, call it renal capsule, and then renal cortex, and then renal medulla. And the renal cortex, we have glomeruli and formation ductule, and then accumulation to form renal pelvis inside the kidney and go outside and form ureter. The function of the renal system, renal function is required to maintain normal body fluid volumes and composition, include acid-base balance, to exert many metabolites and drugs, to synthesize vitamin D and erythropoietin enzyme within the kidney. The part that filtration of the blood is called nephron. The nephron make urine by filtrating a small molecule and ion from blood and then reclaiming useful material. According to osmolality of different regions of the kidney, there are different parts of the nephrons. The nephron consists of Bowman capsule that's surrounding of the nephron by a certain connective tissue that surrounds the glomerulus. This is capillary network within the Bowman capsule. Blood leaving the glomerulus pass into second capillary network. And from the glomerulus, they have proximal converting tubule. This by active transport reabsorb all the glucose and amino acid and most of uric acid and inorganic salt. From a proximal convoluted tubule to lobe of Henle, here water continue to leave by osmosis. And then distal convoluted tubule, here more than sodium ion is reclaimed by active transport and still more water column followed by osmosis, and end with collecting tubule. Here there is a final adjustment of sodium and water content of body, and the surplus or waste molecule and ion are left to flow out as urine, which passes to the pelvis to kidney of the kidney, from where it follows to the bladder and periodically on the outside ward. This figure shows the nephrons, the glomerulus, and then the first part of the tubule that have then go to the loop of Henle and the distal convoluted tubule, from proximal convoluted tubule to loop of Henle to distal convoluted tubule and to the pelvis and to outside of body. And we have the blood that entered to the kidney to filtrate to renal artery and filtrated the blood outside of the kidney through renal vein. This figure shows the nephron part and the part of the nephron glomeruli, distal convoluted tubule, lobe of Henle, and distal convoluted tubule to the collecting tubule to the pelvis and to outside of body. This figure shows the part of the nephrons from glomeruli which enter and outside of the molecule, and the mineral part and the water, and then formation of urea. Nearly 1/4 of blood volume perfuse the kidney each minute. The glomerular filtration rate is calculated from creatinine clearance, inulin clearance, using chromium labeled EDTA. Plasma creatinine level in healthy is normal 120 ml per minute over 1.73 meters square. For women, for 130 ml per minute per over 1.73 millimeter square for women. This figure shows how enter the blood and this foreign material and calculation, and then that have formation of urine. In selective reabsorption, sodium, amino acid, and glucose are reabsorbed from the filter back into the blood. This figure shows how the filtration of the capillaries within the glomerular that have a red blood cell in reality much bigger than the rest, and the plasma that go within the capillaries on the bloodstream. A useful substance, example glucose, amino acid, return, waste substance like urea, excess salt go out, and formation of urine. This figure shows the renal artery and the renal vein. The renal artery with the go to the glomeruli in a cortical part of the kidney and go clear blood, leave the kidney and formation in the urea within the ureter and go outside of body. This figure shows the how the urea go and fill the gallbladder and go to the urethra outside of body. The kidney also act in excretion of drug and hormone. The kidney also act as endocrine organ for the synthesis of hydroxycholesterol as active vitamin D, erythropoietin, and renin and prostaglandin enzyme are target organ of parathyroid hormone and aldosterone. This kidney remove waste from blood, secrete hormones, and help regulate blood pressures. The most important diseases that affect of kidney is renal failure. This renal failure means loss of renal function result in low granular filtration rate. When the granular filtration rate reduced than normal, it lead to have loss of function. So I can see in this figure, the first one is a normal, and starting of the granular filtration rate reduced that lead to renal failure in third figures. Renal failure may be caused by pre-renal condition and interrenal condition and post-renal condition. The pre-renal condition such as renal hypoperfusion in severe shock or hemorrhage, renal diseases such as trauma disease or drug damage, and intrarenal direct damage to the kidney by inflammation, toxic drug infection, or reduced blood supply, and post-renal conditions such as obstruction of renal outflow by calculi, prostatic hypertrophy, or trauma that have beyond the renal, the kidney, that have any obstruction to the urinary tract, that have returned the urine and lead to renal failure. We have two categories of renal failure, either acute or chronic categories. The acute kidney injury that have renal causes 20% to 40% lead to glomeruli, vascular problem, and tubulo-interstitial problem. Pre-renal between 3 to 60 that have developed through volume depletion, like diarrhea or severe hemorrhage or decrease in cardiac output, or renal vascular disease like stenosis, embolism, or taking any non-steroidal inflammatory drug. Our other causes is post-renal that have the problem between 1 to 10% that have any stone or any problem in the bladder or urethra that return the urine to the kidney. The renal failure can come on suddenly, acute renal failure, as after surgery or severe injury, or when blood vessel leading to the kidney become obstructed. Or renal failure more usually develops slowly, like chronic renal failure. The two types of renal failure, acute and chronic. The acute kidney failure develop within hour or day, include chance of kidney function recovery. The possible causes: trauma, acute intoxication, part of malignant failure, various other diseases like infections. The chronic type kidney failure develop over a year, irreversible at the end. Possible causes is secondary to high blood pressure and diabetes, or chronic bacterial inflammation of the kidney, cystic kidney, various autoimmune disease. Renal failure results in fluid retention, acidosis, accumulation of metabolites and drug, damage to platelet leading to bleeding tendency, hypertension, anemia, and endocrine effects. In acute renal failure, the causes etiological factor of acute renal failure is pre-renal factor, about 50%. This is due to renal ischemia, severe burn as a result of shock or dehydration, or renal thrombosis. Hypotension, sepsis, heat stroke, drug causing renal shutdown, like drug, non-steroidal anti-inflammatory drug, and other. Second causes is renal factor, is about 50%. Renal disease such as interstitial nephritis, and etc. Third type is obstructed urine flow, about 10%. And the last one, toxic acute tubular necrosis, about 5%, that include complicated surgery or trauma, myoglobin, block tubular function. The drug that lead to toxic acute renal failure is contrast dye used in arteriography, antibiotic, especially streptomycin, gentamicin, or amitriptyline, aspirin, epinephrine, and other non-steroidal anti-inflammatory drugs, and acetaminophen overdose. The toxin material, like heavy metal, solvents, and excessive amount of alcohol. Multiple organ failure syndrome, in which heart, lung, liver, brain, and kidney totally or partially shut down. This is most often a result of major trauma or sepsis. Hemolytic uremic syndrome, a complex condition caused by the strain of Escherichia coli. The clinical feature of acute renal failure is a medical emergency which causes fluid retention, bleeding often in stomach or intestine, confusion, seizure, coma. The management is dialysis often is required. This is the hemodialysis, and we can discuss it in chronic renal failure. The kidney dialysis is first the kidney from urine which passes to the bladder via and then the kidney is made up of microscopic tube that filter was and blood from artery pass through the colloid membrane dialysis machine, and then the waste the kidney from urine and go to other form and dialysis. And you can see it in these figures, how the step of kidney dialysis. The chronic renal failure. General aspect. Chronic renal failure results from progressive and irreversible renal damage and is shown by a low glomerular filtration rate persisting for more than 3 months. And we can see this figure how chronic renal failure occurs. Chronic renal disease can be compensated by structural and functional hypertrophy or surviving nephrosis. Nephrons to a point which around 50% of renal function remain when chronic renal insufficiency ensures. Chronic renal insufficiency inevitably progresses to end-stage renal disease. So first it begins as a chronic renal failure and then go chronic renal insufficiency and end with the end stage of renal disease. The sequel to many renal and systemic disorders include hypertension. The leading causes of chronic renal failure. Diabetes mellitus is another important cause of chronic renal failure. Approximately 5 to 10% of people with type 2 diabetes living for at least 20 years also develop renal disease. The renal disease such as chronic glomerulonephritis, polycystic renal diseases associated with mitral valve prolapse can lead to dysthemias, embolism, or sudden death. Renal artery stenosis, blockage of the renal artery is usually by atherosclerosis. Renal artery stenosis can also affect young women with fibromuscular dysplasia, which causes the wall of the artery to become thicker. Both these conditions are often associated with high blood pressure. Systemic lupus erythematosus, myeloma, and amyloid disease. Poisoning examples include lead poisoning from lead-based paint, lead pipes, soldering material, jewelry, and even alcohol distilled from old car radiator. There are certain drugs like analgesic nephropathy, the long-term use of aspirin or other non-steroidal anti-inflammatory drug, or large amount of acetaminophen. Chronic renal failure can be exacerbated by virus nephrotoxic drugs such as aminoglycoside or amitriptyline used systemically. Risk factor for chronic renal failure. The main risk factor is hypertension. Hypertension lead to renal failure, and renal failure lead to hypertension. And the other factor like the urinary tract obstruction, that renal stenosis, environmental risk factor, heavy metal, drug-induced analgesics, gold, radiographic contrast, and other systemic disease, smoking that lead to hypertension, and obesity that lead hypercholesterolemia and atherosclerosis and thrombosis, the diabetes that lead to hypertension or directly renal failure, glomerulonephritis that lead to hypertension and lead to renal failure, infection, chronic pyelonephritis, and hereditary and genetic factors like polycystic kidney diseases. Clinical feature of chronic failure is asymptomatic at first, and the symptom and sign of chronic renal failure depend on the degree of renal malfunction. Often, with few symptoms until kidney function has fallen to less than 25% of normal. Chronic renal failure then manifests with the nocturia and anorexia and rise serum level of nitrogenous compounds such as urea and creatinine from a normal metabolic process and change in electrolytes. This figure shows the sign and symptom of chronic renal failure, that renal insufficiency that lead to edema, headache, ability to concentrate urine, polyuria, oliguria, and proteinuria, nitrogen, serum, creatine in the blood, weakness and fatigue, increase in blood pressure, mild anemia, and glomerular filtration rate progressively decrease from 90 to 30 ml per minute. The sign and symptom divided in according to the metabolic activity, nocturia and polyuria. First, the glucoseuria, serum urea, creatine, lipid, and uric acid electrolyte disturbance. Secondary hyperparathyroidism. The cardiovascular disease sign is hypertension, congestive cardiac failure, pericarditis, cardiomyopathy, erythema. Gastrointestinal sign, anorexia, nausea and vomiting, and hiccup, and last, peptic ulcer and gastrointestinal bleeding. In neuromuscular system, weakness and lassitude, drowsiness leading to coma, headache, disturbance of vision, sensory disturbance, and tremor. The dermatological sign, pruritus, bruising, hyperpigmentation, hematological sign, bleeding, anemia, lymphopenia, and immunologically sign, liability to infection is more in chronic renal failure. This figure shows the symptom and sign of chronic renal failure that lead to fatigue, bruising, bleeding, nausea, vomiting, NGIT, nocturia, polyuria, and edema in the lower leg and mainly in the feet, pain and muscle weak, switch and cramp, puffy handle, pigmentation of the skin, weakness, hypertension, puffy face and confusion, lethargy, and seizures. Advanced chronic renal failure causes significant impairment of all renal function and affect virtually all body systems and causes change in urea and electrolyte and other blood constituents. Laboratory feature of chronic renal failure rise in blood urea, creatinine, potassium, and phosphate, low in calcium and hemoglobin. Hypertension is common. Electrolytes such as potassium and hydrogen ion is accumulation. Anemia is common in patients who have chronic renal failure. It's due to lack of renal production of erythropoietin, blood loss in the gout, toxic suppression of the bone marrow, and by hemolysis and by shortened red cell survival from hypersplenism. Renal Osteodystrophy is common and appears to cause worsening symptoms after start of regular dialysis. Phosphate retention in chronic renal failure leads to depression of plasma calcium level and subsequently rise parathyroid activity, lead to secondary hyperthyroidism. There is also deficiency of reductive of 1,25 dihydroxycephalosporin, vitamin D3, and calcium absorption is thereby impaired. Parathyroid hyperplasia may eventually become adenomatous and irreversible, lead to tertiary hyperparathyroidism. Purpura and bleeding tendency, as you can see in this figure, the bleeding time is often prolonged, not because of different collecting defect, but mainly from abnormal platelet protection, diminished platelet factor 3, thromboxane, which impair conversion of prothrombin to thrombin, rise in prostacyclin, prostaglandin 1, leading to vasodilation and poor platelet aggregation and defective in one-well-brand factors. There is liability to infection risk because of defective phagocyte function, which results from impaired interleukin-2 and increase in other cytokine, interleukin-1, interleukin-6, and tumor necrosis factors. End-stage renal disease, that call it uremia, is the term used when more than 90% of renal function is lost and may be complicated, particularly by anemia, bleeding, bone disease, and congestion. The feature and granular filtration rate and renal health. We have no any problem, no any in the kidney. The granular filtration rate is about 130 in normal health of renal system. Plasma biochemistry is normal. Is a granular filtration rate is 15 to 100, and diminished renal reserve, early chronic renal failure. Rise plasma-urea and creatinine between the glomerular filtration rate between 25 to 50. It is moderate chronic renal failure. Call it azitomia. Uremic septum less than 25 glomerular filtration rate that lead to severe chronic renal failure. Life-threatening is less than 10% of glomerular filtration rate that lead to end-stage renal failure. Stage of kidney, stage 1, and it is early stage, that beginning of the renal failure. Stage 2 is mild, the glomerular filtration rate between 89 to 60. Stage 3, moderate, the glomerular filtration rate between 59 to 30. Severe is stage 4, the glomerular filtration rate between 29 to 15. And stage 5, the glomerular filtration rate is less than 15, is the end stage. How many patients have chronic renal failure? Is chronic renal failure diagnosed by measuring by failing glomerular filtration rate, rising plasma urea, rising creatinine level. The creatinine clearance is an approximation of glomerular filtration rate, but more accurate assessment are by inulin clearance. Renal function may remain relatively adequate for a long period if the progress of renal lesion is slow, but any stress, infection, or urinary tract obstruction should be treated as a main precipitated septum. Underlying causing of chronic renal failure should be treated where possible. Drugs that are nephrotoxic, such as non-steroidal anti-inflammatory drug, tetracycline, or cephalosporin, should be avoided, as should those that can accumulate in the body when there is impaired renal drug excretion and can produce encephalopathy, such as penicillin, cephalosporin, and erythromycin. Initial measurement aim to lower the blood pressure by using ACE and angiotensin-2 blocker. This also minimizes proteinuria, level of blood urea, electrolytes, etc. by normal diet. Low protein diet are not rarely advocated, potassium restriction, salt or water control. The symptoms and complications such as hiccup, vomiting, fit, and calcium loss should be treated. Butene recombination, erythrobutene, or the darabutene, which has a longer half-life, is the main treatment for anemia. Calcium carbonate, vitamin D3, or its synthetic analog, also phosphate diet or intravenous colloidine, help inhibit bone resorption. Parathyroidectomy may be necessary in resistant cases. The dialysis is used to remove metabolites by exposing the patient's blood across the semi-permeable membrane to a hypotonic solution. Dialysis becomes essential if renal function deteriorated to end-stage renal disease and can totally rehabilitate up to 20% of patients, but cannot prevent all complications and is still associated with some adverse effect. The dialysis effect including a worsened cardiovascular disease, cardiac valve calcification, especially affecting the aortic valve, dialysis related to amyloid condition. The type of dialysis may be either continuous ambulatory peritoneal disease, continuous cyclic peritoneal dialysis, and extracorporeal hemodialysis. حاليا نستعمل هو extracorporeal hemodialysis. Patient on continuous CAPD undergo around 5 manual change daily where there are CCPD. A machine does the exchange at night. Hemodialysis is carried out often at home or as an outpatient for 2 to 3 to 6 hour sessions per week. An arteriovenous fistula is usually created surgically at the waist to facilitate the introduction of infusion line. Alternatively, a cortex or PTEF graft is placed or an indwelling tunneled cupped catheter used. This particularly, the graft and catheter may be at risk of infection. The patient is hypernized during dialysis to keep both the infusion line and the dialysis machine tubing patient. The patient also has an additional bleeding tendency from mechanical damage to platelet from the procedure. Control of infection also of paramount importance during hemodialysis, as infection with hepatitis virus or HIV or other blood-borne agent, and tuberculosis was common in the past. Over 70% of patients on hemodialysis survive at least 5 years. Renal transplantation may become necessary. The renal transplantation from donor functional kidney to recipient non-functional kidney. Dental aspect. The main management problem in patients with chronic renal failure include bleeding tendency. Careful hemostasis should be ensured if oral surgery procedures are necessary. Dental treatment is best carried out on the day after dialysis when there has been maximal benefit from dialysis and the effect of heparin has worn off. The hematologist should first be consulted, should bleeding be prolonged. This operation may provide hemostasis for up to 4 hours. If this fails, cryoprecipitate may be effective, has a peak effect of 4 to 12 hours, and lasts up to 36 hours. Conjugated estrogen may aid hemostasis. The effect takes 2 to 5 days to develop but persists for 30 days. Infections are poorly controlled by patients with chronic renal failure, especially if the immune suppressed and may spread locally as well as giving rise to septicemia. They also accelerate the tissue cataplasm, causing clinical deterioration. Infection can be difficult to recognize as signs of inflammation are masked. Hemodialysis is predisposed to blood-borne viral infections such as hepatitis virus. Tuberculosis is also more frequent but is usually extrapulmonary and therefore does not constitute a risk of dental staff. Pathogenic infection should be treated vigorously. Antimicrobial considerations include erythromycin, fluoxetine, fusidine, and can be given in standard dosage penicillin other than penoxine, methylpenicillin, and fluoxetine. Metronidazole and cephalosporin should be given in low dose since very high serum level can be toxic to the central nervous system. Benzylpenicillin has a significant potassium content and may also be neurotoxic and may therefore be contraindication. Tetracycline can worsen nitrogen and retention in acidosis in chronic renal failure. Only doxycycline and minocycline may be given. Patients who should be considered for antimicrobial prophylaxis before extraction in scaling or periodontal surgery include those with polycystic kidney who may also have mitral valve prolapse, those receiving peritoneal dialysis, since bacteremia can result in peritonitis, some on hemodialysis, vascular access infections are usually caused by skin organisms such as Staphylococcus aureus. Only rarely by oral microorganisms. Patients with most arteriovenous fistulae are therefore not considered at risk from infection during dental treatment. However, those with prosthetic bridging graft of polytriphenylethylene or tunneled cuffed catheter may need to be managed with precautions similar to those at risk from infective endocarditis. Tacopline IV during dialysis, which give cover of at least a day. Antibiotic prophylaxis may also be indicated if there is uremia-related chemical trauma of the heart valve, placing the patient at possible long-term risk of endocarditis. Drugs that are directly nephrotoxic must be avoided. Drugs exerted mainly by the kidney may have undesirably enhanced or prolonged activity, thus are not cleared. Drugs thereby may need to be adjusted depending on the degree of renal failure, the patient dialysis schedule, or presence of a transplant. Except in emergency, such drugs should be prescribed only after consultation with the renal physician. Aspirin and other non-steroidal anti-inflammatory analgesics should be avoided since they aggravated gastrointestinal irritation and bleeding associated with chronic renal failure. Their excretion may also be delayed and they may be nephrotoxic, especially in elderly or where there is renal damage or cardiac failure. Some patients have peptic ulceration, which is further contraindication to aspirin. Even COX-2 inhibitor may be nephrotoxic and are best avoided. Antihistamines or drugs with antimuscarinic side effects may cause dry mouth or urinary retention. Fluoride can usually safely be given topically for caries prophylaxis. Systemic fluoride should not be given because of doubt about fluoride excretion by damaged kidney. Antacid containing magnesium salt should not be given as there may be magnesium retention. Antacid containing calcium or aluminum bases may impair absorption of the penicillin V and sulfonamide. Cholestyramine, sometimes used in chronic renal failure, may also interfere with the absorption of penicillin. Many renal patients are on antihypertensive therapy, digoxin, and diuretic, which may also complicate management. Post-operative complication. The major surgical procedure may be complicated by hyperkalemia as a result of tissue damage, acidemia, and blood transfusion. Hyperkalemia predisposes to dysarrhythmia and may cause cardiac arrest. Dialysis is deferred post-operatively if possible since hyperinization is required. Underlying disease and complication consideration must be given to the effect on dental management of underlying disease such as hypertension, diabetes, systemic lupus erythematosus, polyarthritis nodosa, myelomatosis, amyloidosis, complications such as peptic ulcer that have been considered when have any dental management. Local anesthesia and consciousness sedation. Local anesthesia is safe unless there is severe bleeding tendency. Consciousness sedation relatively anesthesia may be used. The veins of the forearm and the saphenous vein are a lifeline for the patient on regular hemodialysis. If it is necessary to give intravenous sedation or take blood, other veins such as those at above the elbow should be used because of the risk of consequent fistula infection or thrombophlebitis. Midazolam is preferred to diazepam because of lower risk of thrombophlebitis. General anesthesia. Chronic renal failure is invariably complicated by anemia, which is contraindication to general anesthesia is if the hemoglobin is below 10 grams per deciliter. Some of difficulties with general anesthesia are that patients with chronic renal failure are highly sensitive to myocardial depressant effect of anesthetic agent and may develop hypotension at moderate level of anesthesia. Myocardial depression and cardiac dysarrhythmia are especially likely in those with poorly controlled metabolic acidosis and hyperkalemia. Fluorines is metabolized to potentially nephrotoxic organ, ionic fluoride ion, and therefore should be avoided if their nephrotoxic agents are used concurrently. Azafluorine and sulfafluorine are popularly favored. Induction with thiopentone followed by very light general anesthesia with nitrous oxide is generally the technique of choice. Orofacial manifestation in chronic renal failure. The osseous lesion should include loss of lamina dura, osteoporosis, and osteolytic area, renal osteodystrophy. Secondary hyperthyroidism may lead to giant cell lesion. There may be abnormal bone repair after extraction with socket sclerosis. Patients with renal disease should therefore be screened carefully for bone disease before implant placement. Any oral sign of infection must be examined immediately and treated aggressively in an immune-suppressed transplant recent. Common complication of chronic renal failure in the oral cavity that have dry mouth, halitosis, metallic taste, insidious oral bleeding, and purpura can also be conspicuous. The salivary gland may swell, salivary flow is reduced, there are protein and electrolyte change, and there is calculus accumulation. In children with chronic renal failure, jaw growth is usually retarded and tooth eruption may be delayed. There may be malocclusion and enamel hypoplasia with prominent discoloration, but tetracycline staining of the teeth should not be longer seen. Lower caries rate, less periodontal disease have been reported in children with chronic renal failure. The last topic we discuss in the renal system is renal transplantation. Transplantation is not strictly recommended for all patients with end-stage renal disease who are medically suitable. A successful kidney transplant offers enhanced quality and duration of life and is more effective medically and economically than the chronic dialysis. Transplantation is the renal replacement modality of choice for child patient and patient with diabetic nephropathy. Transplant can be formed as cadaveric or living donor. Renal graft survival can be as high as 90% at 1 year and about 70% survival at 5 years, and an overall mortality of less than 5%. The first year life expectancy affecting kidney transplantation is 95 to 98%. How we manage patients have a kidney transplant. All kidney transplant recipients require lifelong immune suppression to prevent T-cell aluminum rejection response. This includes intravenous induction of anti-rejection agent and maintenance immunotherapy. Induction therapy consists of short course of intensive treatment with intravenous anti-lymphocyte antibodies. Patients then need to be immune suppressed, usually a corticosteroid plus steroid-sparing drugs such as azathioprine or, no more commonly, cyclosporine or tacrolimus or sirolimus or mycophenolate mofate. The complications that occur within kidney transplant, medical complication and surgical complication. The medical complication is infection, acute rejection, delayed graft function, chronic allelographic dysfunction. Surgical complication, periodic stenosis, severe RAS, urine leak, renal allograft, and wound hematoma, and renal allergic infection. The complication during renal transplantation, surgical and medical. Surgical lead to high obstruction, hematuria, urinemia, arterial stenosis, arterial thrombosis, renal vein thrombosis, post-operative hemorrhage, and lymphocele. And medical complication, acute rejection, acute renal failure, delayed graft function, acute cyclosporine, tacrolimus, and nephrotoxicity, the pre-renal azotemia, drug toxicity, infection, and recurrent diseases. Post-transplant urinary problem, the stricture were the most common urinary complication, and then the leaks of the urine and stones or internal hematosis. Dental management for patients have a renal transplant. The hematological abnormalities such as anemia and platelet hemostatic dysfunction, gastrointestinal abnormalities such as gastritis, peptic ulcer disease, or diverticulosis, viral hepatitis B and C, cardiovascular disorders such as hypertension, atherosclerotic heart disease with myocardial infarction, congestive heart failure, and left ventricular hypertrophy. Bone and joint disease common because of low calcium level, high phosphorus concentration, and elevated serum parathyroid hormone. Dental pulp gnawing has been noted, apparently a corticosteroid effect. Thank you for listening to this lecture.